Looking at chapter 66 right now on mechanical ventilation, and the whole focus of this PowerPoint, if you'll get it out, and you can look along, it starts out with a case study of a lady who's having some trouble breathing, and you get a few labs on her and a bit of history, and she ends up having a blood gas, and if you'll interpret that blood gas correctly, you'll notice that she has a respiratory acidosis, and she also has crackles in her lungs. So the point of this is going through the process of intubating someone, and then criteria for intubation is the focus, and then criteria for extubation. In generally speaking, criteria for extubating someone and taking them off the ventilator is a resolution of those things that cause them to be on in the first place. So in her case, she does have a hypercarbia, or increased CO2 in her bloodstream. She also has a decreased amount of oxygen, and she's on a non-rebreather mask. So you need to interpret those. Artificial airways are airways, of course, that are artificial, going to the trachea. And you're going to see these in your clinical rotation in the ICU or in the emergency department. They come in different shapes and sizes, and provided by different vendors, different companies. Generally speaking, in terms of adult population, we're going to probably not want to go smaller than a 7.0, and that's the internal diameter tube. Hopefully you get a 7.5 or an 8.0. That gives you more room to breathe through the tube, especially during mechanical ventilation. I mean, we can do tracheostomies, and also prior to being intubated for respiratory failure, a lot of times we'll try mask non-invasive ventilation, but the patient really needs to be alert for that and cooperative. So there are some indications: upper airway obstruction, respiratory failure, inability to breathe, of course, dyspnea. So we look at the respiratory rate, we look at, are they tachycardic, are they hypotensive, are they alert? If they're alert, that makes a big difference for altered level of consciousness. And of course, there are risks inherent. I would look at the slide 8 too, that shows you pictures of your ET tube and the different features of it, how we actually get air into the cuff that's inside the trachea. Most of the time we're going to orally intubate. It's a little less traumatic. It's pretty difficult to intubate nasally, although it can be done. So the healthcare provider in this case study in your PowerPoint is going to elect to intubate. So nurse's responsibility, and hopefully you'll get to be part of this in your rotation, is to collect the equipment needed, the drugs, of course, for sedation and for paralysis. We typically use etomidate and succinylcholine. That's fairly routine unless they have some other issues going on, especially with succinylcholine. It can be a little injurious to the kidneys, so they might use someone else if they already have existing kidney disease. A bag and mask, of course, suction, Gonkar suction, and things like that. When we intubate someone emergently, we call it RSI, or RSI, rapid sequence induction. We confirm ET2 placement first by auscultation over both lung fields and over the epigastrum. And we look for a change in the CO2 detector that's put on just after intubation. Make sure there's CO2, which would indicate we're in the lungs. And the last thing we do is we get a chest x-ray. And also we'll get blood gases. It allows us a way to facilitate suctioning of the airway, and of course mechanical ventilation has several different kinds of modes, which I'll address in a different recording. These recordings that I'm doing are going to be in little, probably 5-minute bites. So I'll leave at frame or slide 20 that talks about following the intubation, what we have to record. And we record landmarks like where at the tube, there's marks on the tube, centimeter marks, and then also is it at the lip, at the teeth, at the gum, and what size tube it is. Okay?